chair the first plenary session. Okay. I'm inviting Dr. Sudip Kumar to introduce Dr. Jay Kaldra. Okay. Dr. Sudip Kumar Datta is the head of the department, Lab Medicine, AIIMS, New Delhi. He is a technical assessor of biochemistry at NABL. He is an alumnus of Calcutta National Medical College. His area of interest is a total lab automation in diagnostic laboratory. Dr. Arvind Lal, he is an eminent pathologist, a medical administrator, chairman, and managing director, Dr. Lalpath Labs. He holds the rank of brigadier in the Indian Armed Force, an honorary rank conferred by the Army. His incorporating information and computer technology systems, Lalpath Labs, have branched out to many parts of the country. He served as a honorary physician to the Indian President in 2001. He was one of the founders of Indian Chapter of Association of Clinical Research Organization. His awards are Padma Shri, Healthcare Lifetime Achievement Award, Indira Gandhi Solidarity Award, Eminent Medical Person Award, Delhi Ratan Award, International Business Council Award. I now invite Dr. Sudip Kumar to introduce Dr. Jay Kaldra.
Good morning, everybody. I think this is the first academic session of this conference, and we have three very eminent speakers with us. The first of them is Dr. Jay Kaldra. He is a professor and clinical pathologist in the Department of Pathology and Laboratory Medicine, and has served as departmental head of Pathology and Laboratory Medicine in Saskatoon Health Region, that is in Canada, University of Saskatoon. And he has served as national president of numerous medical associations and scientific societies, including the Canadian Association of Medical Biochemists and Canadian Association of Pathologists. He was a founding member and director of the Saskatchewan Stroke Research Center. He currently serves on the board of directors of Saskatchewan Medical Association and its Legislation and Policy Committee. He has been actively involved as a physician leader in healthcare reform and administrative work, served as clinical chief in the Department of Laboratory Medicine, Saskatoon District Health, and has more than 30 awards and honors, including Rotary Golden Wheel Award for Excellence in Science and Technology, then the Queen Elizabeth II Platinum Jubilee Medal, and has been considered as top 25 Canadian immigrant in Canada. And the list is endless, so without further ado, I invite Dr. Kaldra, and he will be talking on a very important concept, that is error disclosure. And error disclosure nowadays is a very important aspect of laboratory governance, laboratory management, and overall patient safety. Over to Dr. Kaldra, please.
Thank you, co-chairs, honored guests, ladies and gentlemen. I'm delighted to be here. I was telling somebody that I used to be here at the AIIMS in 1969 and 1970 with Professor G.P. Talwar. So it's a privilege for me to return here at this particular very interesting topics. I'm just gonna, first of all, please join me in thanking Ms. Saroj Singh and entire organization committee for doing this one, because I'm going to repeat one statement which our Padma Shri Dr. Lal indicated, and I practice that 70%, 60 to 70% of diagnosis, you people help in making the correct diagnosis, which is primarily credit for all my laboratory technologies. So please give applause for yourself. With that in mind, let me just start, because I have 30 minutes and I'm going to do a justice to that. So let me just move forward. I have no conflict of interest. Let me start by showing you a cartoon. This cartoon is between discussion going on with the physician and Dilbert. The physician is already indicating that it seems we had a mix-up with your test results. So the Dilbert very probably shake up his shoulders and say, then I'm not dying. The doctor says, we doctors are amazingly smart, but occasionally we make an error. The Dilbert walks away. Well, I understand. The doctor shouts it. By the way, your pap smear was normal. So you can appreciate it. Keeping that in mind, let me pose a question with you. When a mistake happens at the work, what do you do? Do you punish the person, or do you work with the person to make sure that you alleviate that particular mistake? And especially, mistake is a major concern in any industries, but in healthcare, it is a major, major concern because it affects our loved ones when they are in hospital or when they are patients, primarily. So that raises a lot of questions related to that. It's primarily that you can see that particular slide shows it, all kind of concerns comes into the picture. Because we as a physician and lab technologists, we want to make sure that we eliminate all the errors and provide the quality services. And that raises all kind of concerns related to ethical, morality, regulations, what is happening, and how should we diagnose, how should we actually relay that particular information to our patient. So my learning objectives would be basically I'm going to take a few minutes to talk to you about magnitude, scope of epidemiology of lab errors, and then we'll talk about national and international disclosure policies along with what has been happening across Canada, and provide you with the best practice model which we can use. This is primarily, we just finished this one. It has already been in the press, so it is being accepted at most of the places in the world. So let me start by showing you a case, which is a 55-year-old Mrs. Burns, whose surgical biopsy of the breast, a physician who is very busy and long wait list, is primarily walks in his busy schedule and enters an examining room and says, how is Mrs. Dawn doing today? Now let's finish that endometrial carotid. I love to talk interactive. So what does this case indicate to you? If you really think about it, if you have not caught it, this a wrong patient, wrong procedures, that creates a lot of things that you have to think about it, eroding quality and also the patient safety. Along with in the last 8 to 10 years, it has raised the point what we call professionalism. For a physician, how much they have work to do, how many patients they should see. This is really indicated in our country, in Canada also, and across the globe, to raise the professionalism itself. And in the news, every day, you see that in the news in North America, and also here. When was the last time when a patient went for right knee surgery, ended up getting the left knee surgery? Right? And when was the last time you saw that? Let me share with you the unique, true stories. 58-year young lady who had an abdominal surgery is primarily, then after 6 weeks of surgery, she's going to travel and see her son at the airport. Beep, beep, security is coming every time. And then finally, through the x-ray, they found out the surgical instrument was left. And a neonate who was supposed to get heparin ended up getting insulin. So if we just have a glance at this particular time, from since 1999 to Aries human, medical error causes about 44 to 98,000 hospital deaths. And it costs the system about $17 to $29 billion in US. And if we extrapolate this one, it will be costing the lab unnecessary, repeating the test and other things in the vicinity of about $5 to $6 billion. 95% of the physicians were surveyed tell they're witnessing an error primarily. And 60% or so, the healthcare professional believe that error is a routine part of the services. One of the 5 most common medical errors are due to is by misdiagnosis, delayed diagnosis, medication error, infection, and also the bad medical devices. So this slide actually just put things together that the third leading cause of death in US is primarily the medical error after the heart disease and the cancer. Let me share with you another case because I'm trying to put together the interrelation of medicine and the lab medicine in one. So this is a case where it's primarily a 36-year-old female who was pregnant, first pregnancy, had a test done, low protein S, and it was one that is a risk of thrombosis. Clinician was unaware of the low protein S value in the pregnancy without thrombosis. Lab results was misinterpreted, and the outcome was woman terminated pregnancy. This raises a question, who is responsible for this? Is it the lab or is it together where we are involved in this? So my question now is with you, how many of us have made a mistake? If I ask you to raise your hand, would you tell me that how many you think that you have made a mistake and what did you do? How many can raise the hands that if you have done the mistake? I only see one gentleman here. Let me share with you this one, and what did you do? I have my own stories but I'm gonna tell you what I've done the survey and what people tell us they did. So you made a mistake. All right, will it show? No, bury it, problem solved. You don't have to worry about it at all. Yes, will it show? Can you hide it, conceal it before your boss or other people find out? Problem solved. Now, it's primarily, can you hide it? No. Can you blame someone else or a special circumstance? Yes, then get it there. Sir, it wasn't me. It was Johnny who did the mistake. So you are covering yourself. Could your admission to the damage over career? Yes, then you have to sit tight and think the things will go well. It's primarily, so this is a conventional way people have been doing it, especially area. So this is just a slide to show, just to give a cartoon, and I'm sure that you understand this was when we had the genetically sheep twin was produced in the world literature. So let me tell you how frequent it is in the error for the lab. One identified error occurs at any 330 events. You can have it for about 900 to 2,000 patients or about 280 to 8,000 lab results. And this all varies because how the different studies are reported and what is the process they have used for diagnosing or telling that there was an error happen. Also, this slide shows what I like to call the brain-to-brain loop. And here, when a patient is seen by a physician, is primarily looking at after taking the history and doing the examination, he or she has already made up their mind what kind of differential diagnosis is there, and they try to order the test. Samples are collected, identified, transportations, preparation, analysis, reporting, and interpretation in the mind of the physician, who then uses those test results to indicate, rule in or rule out that particular diagnosis he or she had made it. And this is when we talk about in the lab, which is a very complex, but at the same time, we have a laboratory data and management, safety, customer services. So we usually divide it into three parts: pre-examination or pre-analytical, examination or analytical, and post-analytical phases. You can look at it that the pre-analytical phase is from the time the blood has been collected from the patient till it reaches the lab, and analysis is done in the lab. Post-analytic is what we call post-transcriptional, or when we report the results. This is you can look at the pre-analytical is primarily right now at this year, last year we retabulated this. Pre-analytical errors are about 95% now, 85 to 95%. Average comes down to somewhere 85%. And then 7 to 8% analytical, and the post-analytical 7 to 8%. And this slide just to impress you that things do happen. There is a particularly review of literature is that the laboratory errors varies from 0.1 to 9.3, depending on what kind of studies are done or how they were analyzed primarily. So when the mistake happened, how quickly you can find it out? As I mentioned to you, if you went for right knee surgery and you have the left knee surgery, it was very easy to find out. But what happened when we are involved in the lab? How quickly we can find it out? It's primarily, if you look at, if you have incorrect or insufficient laboratory test order, it's very low error recognition is there. Laboratory test misinterpretation, again, we are not aware of it because it is done on the other side in the physician hand. So there is a primarily critical in the patient care, it has a very low risk or low priority. So what are the consequences of these laboratory errors? What is it happening? It's an inappropriate test selection and results interpretation can result in many other things because from the waste and loss of physician and laboratory staff time to increased cost of care, and along with the diagnosis are delayed, and that has emotional, clinical and emotional consequences for the patient and the doctors also. So you can see that how many consequences could be there. So how do we handle these mistakes at work? What do you usually do that one? We have previously reported and suggested from 2001 onward that addressing medical error and critical events should include educational program. We have introduced an educational program for all allied health sciences, nursing, and other places. And this is very well received across the world literature now. And I was glad that earlier on somebody had mentioned, one of your presidents had mentioned that this is something, innovation and teaching, we have to keep up with the training. So that's another. Part of accreditation, the hospitals and all the labs need to be accreditation, so it has to be part of it. And we suggested a no-fault, non-punitive model, which has been now very well received across the globe. So what is this no-fault model when we talk about? The principles, the highlight of no-fault model is a anonymous, non-punitive, and it has an organizational commitment. And that is very important. So what actually happened, this no-fault model, which I've shown here, we divide into 3 parts. It's primarily, if you look at, if you made a mistake, volunteer errors, and you report the incident report to, so we take it at a departmental level. It's primarily, that's the first instance where you have the report, division head or the lab managers looks at it and take appropriate actions. If it has to go to the quality committee or wherever you have the standards to look at it, it goes through it. Or it can go to the lab advisory committee who can look at it overall, what's happening from the lab, and come back and tell the solution so it will not happen again. The second part is related to when it's an institutional level. So it's primarily you have a lab advisory committee can put that forward to the medical advisory committee where all the physicians are there from various departments and they look at it, how to deal with it. And the last one is primarily when we can bring it at a national level or a provincial level. So this model is very well received. We proposed this in 2013. Now it's almost everywhere we see that this use is done. So the pillars of this error reporting is primarily say non-punitive, confidential, prompt, and result-oriented because you want to let the people know what has happened. So if you want to look at the disclosure of medical errors from a global lens, is primarily, let me tell you, what are the concepts? Disclosure of medical error is a challenge. Do you want to report it if something has happened? Or you just want to sit back? Other thing is there, many studies have indicated medical errors are infrequently disclosed to patients or their families. Physicians and healthcare provided 95% of the physicians say they will disclose, but in practice, only 30% of the physicians disclose the medical error. Then again, on the other side, patients' right to receive accurate information, what we like to call the patient bill of rights to make informed decision about medical error. So there are a lot of, from a quality perspective, when we look at it, it's primarily the error disclosure may be viewed as an informed consent. When you have given the physician informed consent, it's physician's duty to make sure that you are keeping up with the fiduciary patient-physician relationship. Also, open communication with the patient about error is not seen as a common practice. And it provides an increased honesty and openness if we are open with the patient. Well, there are concerns, because many of us believe that why not to disclose? Error is trivial, nobody cares. Other thing, the error doesn't harm. Patient is ignorant about the concept of error. Excuse me, Dr. Google is not going to be happy to know the patient is ignorant. May impair the patient trust in the physician and may increase the emotional liability. So there are factors, what I like to call the systemic barriers to disclosure. That's the first is tort culture. If I tell the patient I made a mistake, I could be taken to the medical legal case by the insurance company or in the court. Regulatory issues, if I'm reported that I'm making mistakes, I may lose my license. How I'm going to feed my family? There are no uniform policies were there. Fear of peer reviews is primarily mortality, morbidity, rounds are there every month in various departments. They look at it. It's primarily you don't want to say from your peer to say, oh, don't go and see Dr. Kalra. He makes a lot of mistakes. So you have to be very careful what is happening and what are the benefits of this particular ignorance. So we created certain principles which are primarily confidentiality, institutional support, acknowledgement and apologize, open and timely communication, and recognize as patient's expectation, what we like to call patient-centered care. And there is also a need of balance. Of course, we look at the non-punitive dealing with the providers along with the ethical and legal requirements of accountability, which provides us that we have to balance the approach so that we can do the quality work and report accordingly. So who should report it? When it should be reported, and what should be reported? When we come to the patient disclosure, we talk about who, when, and what. Who is the individual who knows most about the patient should be the one. When to disclose? As promptly as possible. When to disclose, what to disclose is a process. Then what we need to do is avoid speculating and start with the expression of regret or apology and try to disclose that. Disclosure follow-up is also important because if you disclose, then you have to make sure that it's an important step. And you should be doing it occur at very occasionally, very quickly, the possible opportunity you get every time. You should talk to the family and make sure that all their answers, all their questions are being answered appropriately. And afford opportunity. Many times the patient can refuse for disclosure process. What are the consequences if you don't disclose? Broken trust with a mutual respect with your patient, ethical challenges, and financial factors. The physicians are taken to the court for medical legal cases if they have not disclosed. And it has been indicated in the literature many times that there is at least 30 to 40% decrease in the medical legal cases when the patient has been told about the error and they have not been taken to the law. In the meantime, when we're talking about patient-centered, what does the patient want to know? Do the patient want to know that if mistake happened? At least 98% of the patient want to know the truth. And they are interested to, they verbalize that disclosure would enhance their trust in their physician honesty, and also disclosure will reassure that they are receiving the complete information about their healthcare. So how do we go about and set it up there? It's primarily the medical error disclosure guidelines in various countries. There are three things which are required. Number one is the requirement. It's a multifaceted approach where it's required legal reform, culture changes, and institutional framework is required. This will encourage the transparencies, patient safety, and the trust. And it will bring overarching principle, honesty, transparency, apologies, and learning from the errors. And these guidelines are aimed to enhance primarily patient trust, improve safety, both for patient as well as for the healthcare provider. If we look at the globe, international, US, with a joint JCAHO, which is a commission, and they have a medical error disclosure as a accrediting standard. UK, they indicated that the medical error disclosure is a remedial, they provide a remedial care, apologies, and monetary compensation to return to make sure there is no concern related. Australian studies indicate medical error disclosure as an integrated disclosure with risk management analysis to provide and investigate the critical incident. In Canada, it's primarily, this slide shows you the Canadian Provincial College of Physician and Surgeon policies on disclosure. These are the regulatory bodies who provides the license for physician to practice. It's primarily, if you take it from Saskatchewan, the first in 2002, it was introduced, apology is a part of standard. Manitoba, Winnipeg, is no speculation, avoid the speculation. Ontario, patient can refuse to be involved with the disclosure. Also, in the British Columbia, we brought a law that prevents the apology as an admission of liability. All these disclosure policies are supported by medical association, Canadian Medical Association, and also Canadian Protective Medical Association support disclosure and also provides the training program. This slide shows you across the board, almost in Canada, all the regulatory body has this disclosure policies. When we talk about the patient-centered care, it's very important, we also decided to go from the regulatory body to come to the hospitals or the health regions. And we reviewed, evaluated, and compared individual policies of Canadian provincial and territorial health region to provide guidelines for the best possible medical error disclosure or model. And we use certain five of the evaluating key points: expression of regrets, patient support, avoidance of speculation, avoidance of blame, and provide support. This study was primarily, there was a Quebec and Yukon, data was not present because of its completeness. Otherwise, what we found out when we compared these 5 factors, and we tried to take the average of 5 factors across the country, we found that 90% plus in all the policies where these factors were involved. It's primarily, you can take it from avoidance, apologies, blame, and provider support was there in 90% of the. And then what actually happened is when we applied this thing, we found out 7 of the provinces and territory had these, which are marked here: Nova Scotia, New Brunswick, Prince Edward, Newfoundland, Alberta, and Saskatchewan. They had all these factors included in their health region medical error disclosure. And that's what primarily tells you that in the western part, Alberta and Saskatchewan, and the Atlantic part, and also one of the territory had this particularly disclosure policies included all those 5 factors. Now, we talked about it, all these things, but let me ask for your help now. It's primarily, if we can look at it, this is a 31-year-old woman. She went to see her family physician office, routine checkup. The physician discovered an old pap smear was in the report, which was done 3 years earlier, but unnoticed until now. The report reveals the carcinoma in situ. Is primarily, although the patient had not been has been seen many times, but this report was not consulted or brought to her attention. So my question is, what do you do next? Do you disclose, or do you just keep it quiet? And what to disclose and how would you disclose is primarily. Let me share, where do we go from here? It's primarily time for some answers to think about it. Does the patient have the right to know? If so, when and how? How much the patient need to know? Do they still need to know if it is a near miss? How important is apology and timely of apologies? Should worker be punished for their error once they have reported it? It's primarily. So taking this particular case, what should be done is a professional dilemma for people. Number one is do nothing. You have nothing to worry about it, as I showed it to you earlier on. Second thing is that you can make a statement of regrets or sorry, apologize, it happened, and then you don't do it. Report it to the, or you tell the patient, we'll report to the department and we do the root cause analysis and we'll get back to you. The last one is, which is the right thing to do, is tell the patient the detail of the mistakes and apologize. Tell the patient that the hospital will investigate how it happened, and when that you have the information, you will share with the patient. This particular occasion, the patient should be ensured that the report of adenocarcinoma in situ was accurate and is in the right chart, because Gene Smith versus Joan Smith was the problem where the mix-up took place. And tell the patient before the examination about the report. The third thing is that false reassurances to the patients are no helpful. Blaming your staff will not help us. The patient should be offered immediate and thorough examination and reevaluate the entire what is happening in the office so you can indicate effective and quality management along with the reporting. And this is primarily in the cytopathology, publication in cytopathology indicated to know about error disclosure and how to say I'm sorry and when to say I'm sorry. This is primarily, we were reported in this particular journal where our group was shown that its no-fault model has been an integral part of this disclosure policy. Also, there were studies, there no blame and no shame. Also, when we were asked, we believe that it is our ethical and moral duty to provide the disclosure error as a standard of care, just similarly to what you're going to give the patient a medication or other things. And this primarily takes it our view. Error disclosure should be standard of care. Disclose promptly, be a leader, offer a second opinion if patient requires, emotional support, and document all particular discussion with the patient. And this is very important for total quality management. In summary, it's primarily medical errors are inherent in healthcare. An honest and personal response to an error is an ethical and professional responsibility. Also, a prime role exists for the accrediting and regulatory authorities to provide a driving policy changes and requires uniform guidelines, standard, and program for disclosure. With regards to the best practice, the designing of an error disclosure policy requires integration of various aspects, including bioethics, physician-patient communication, quality of care, and team-based care delivery. The 5 critical components which we have shared with you are there to make a uniform policies creation. Also, we suggest the practice of disclosure in Canada, and we have extended this to different parts of the globe, should transition towards a uniform patient-centered approach that will address errors in non-punitive, foster a culture of learning dedicated to the reducing the error and enhancing the patient service. And this is, we therefore suggest that uniform policies centered about addressing error in a non-punitive manner should be a standard of care. In conclusion, I'd like you to consider this thought. Disclosure when happened and when done properly, appropriately, makes sense from ethical standpoint, professional obligation, risk management, regulatory and license compliance, and legal perspective. And this, I'll leave you with this particular quote: 3 things cannot be hidden, long hidden: the sun, the moon, and the truth. With this in mind, let me acknowledge many of my colleagues who have been involved with us for the last 25 years. This year it makes the 25 years of our work in this particular area. And we like to just, because one of my predecessor, Dr. AIIMS, he was the author of the Doctor and the Law book. And I have 3 of the law students who participated with us during our studies, and I have many number of physicians, residents, now they're practicing in different part of the country, and some of them they have been involved in these studies. With that in mind, I'd like to thank you. If there is a time permitted, through the permission of the chairs, I will be delighted to answer any of the questions you may have.
Thank you. Thank you, Dr. Kalra, for your very insightful and thought-provoking lecture. And this is an area where I don't think India has been having any policy or guidelines. Any questions from the audience?
Yes,
you
please.
have one question. Yes, please go to the mic. Use the mic.
Can you take us the mic? Okay.
First of all, myself, Dr. Gini Bharti, Senior Resident in the Department of Laboratory Medicine. As you mentioned, to not keep mistakes to ourselves. But however, in India, we know that revealing everything to the patient can be very risky. So how can we apply these things effectively in Indian context?
Thank you very much for asking that question. I've been spending a lot of time and thinking about it for a long time. I had some negotiation and communication with Dr. Datta here. And let me share with you. I will only start with a couple of words, and then I'll ask the chair. Both the chairs are very well versed about in this area. Maybe Dr. Datta or our Honorable Padam Shri Dr. Lal may address that to you. What I've looked at it, the awareness is very important. And then with the awareness, the training of our colleagues is going to be very important. Because that's not happening. I came across one case long time ago that went up to Supreme Court and it was thrown out. So that awareness, training, regulation, ethical issues, all these things which I put it there is primarily will be very helpful. And as I indicated to you, I've been doing some collaboration with Dr. Datta, and maybe he can address to you what has happened in India so far. With your permission, Dr. Datta, would you please?
I would like to say that in India, still now, we don't have a clear-cut guideline for disclosure of errors in the laboratory, and I doubt whether it is existing for medical errors as such. But it's very important that we create an environment, especially in the laboratory, where this disclosure is encouraged. Otherwise, we all will accept the fact that if we work, we'll make mistakes. If we don't have the opportunity of disclosing our mistakes, then these mistakes will have very big outcomes. But if it can be identified and rectified at the very early stages, it can be prevented. Those bad adverse outcomes can be prevented. So I think it's very important that we work on this area, maybe assist each other, learn from each other, learn from the global scenario as well, to create some guidelines. I would like Dr. Lal to please comment, sir.
Please.
Thank you, Dr. Datta. The fact of the matter is that what is ethical and what is non-ethical. Now, to make a mistake is bad enough, but to keep hiding it is even worse. So you are the youngsters of tomorrow, and right now, as you have seen that the guidelines are not there, but I am sure the guidelines will come in, sooner than later. And it is much better to say sorry, what Dr. Kalra has said, and say that, well, it is a mistake on our part, and that gets, it gets, finished right there and then. Otherwise, you have to keep on explaining. You tell a lie, and to cover up that lie, you got to tell another 100 lies. And in India, where people are very fond of increasing your writing work, you will keep on writing page after page, and trying to tell something which is actually not happened to protect yourself. So I firmly believe Well, we test 100,000 patients a day, and it is impossible that mistakes are not committed. And I can give you a very good example which happened right with me. And one evening, one husband, wife, Sadarji and his wife, young people, they came up to my room and they said, Dr. Lal, I've got to thank you and I've got to congratulate you. So I did not know what was coming. And he says, well, I'm a diabetic patient, but today you have declared that I have no diabetes. So before I could say anything else, he says, but my wife has got diabetes now. So both were being bled, side by side, and inadvertently the tubes or the label or the thing was mixed up. And so I told him, I said, look, it seems to be a error on our part, and would you like to repeat the test, etc. He says, no, we'll whatever you tell us to do. So we just changed the results, and he was happy with that. But had I said, no, we have not made any mistake, and your wife today, who's never been diabetic, is diabetic, etc., it would have been a real big mess. So I think we should stop there. Thank you.
Thank you kindly.
Thank you, sir.
Thank you, Dr. Kalra.
Thank you so much, sir, to happily come all the way from Canada to educate us on the said topic. I now invite our Honorary Brigadier, Dr. Arvind Lal, to honor Dr. Jaya Kalra with the token of appreciation, a memento.
Okay.
Thank you, sir. So the next talk, the plenary talk, is by Padma Shri Honorary Brigadier Dr. Arvind Lal, sir, Executive Chairman, Dr. Lal Path Labs. Sir, welcoming you, sir.
So it's my pleasure to invite Dr. Arvind Lal, Honorary Brigadier and Padma Shri, to present his plenary talk. I think Dr. Lal is a household name nowadays in India, and he really needs no introduction before this audience of medical laboratory sciences. So without further ado and without wasting our time, we invite Dr. Lal. Dr. Lal, please.
Thank you so much, Dr. Datta. Thank you very much. So, ladies and gentlemen, because of the eternal shortage of time, I shall try to be brief. And I have got I'm an elderly or older person now, so I can't remember so many facts and figures. So I have noted down a few things. So first of all, it's indeed a great honor to be a part of the 5th National Conference of Indian Confederation of Medical Laboratory Sciences, ICMLS 2004. I would like to thank the organizers of the conference, especially Dr. Kaptan Singh Serawat, President ICMLS, for extending this warm invitation to me. Thank you once again. Let us go to a remote village in India. A mother in the village walks a few kilometers carrying a child who has high fever to reach the nearest doctor. Thankfully, she meets a qualified MBBS doctor who examines the child but cannot infer with certainty whether the child is suffering from typhoid, malaria, dengue, chikungunya, or is it the beginning of hepatitis A, B, or C, or something else. He must order a few tests to correctly diagnose and treat the child. And rightly so, as I said earlier, diagnostics are responsible for more than 70% of clinical decisions or medical decisions in modern evidence-based medicine, guiding doctors from uncertainty to clarity and turning symptoms into diagnosis. If the diagnostics are not available in the village, then the quack or the rural medical practitioner, you've all heard this term, RMP, he gives what we call a gunshot 5C treatment. And what is this 5C treatment? That is, no test has been carried out. This means giving a pudia in which is crushed crocin, chloroquine, chloromycetin, crocin to bring down the fever, chloroquine to fight malaria, chloromycetin to fight typhoid, cortisol, which I call in my own North Indian language as Amrit Dhara, it can bring down anything, and of course, cold compresses. So this 5C treatment is given in the absence of any lab test. These are the medicines which even in towns are even being given today by doctors in this very town. The critical role of diagnostics was thrust into the global spotlight during the COVID-19 pandemic. And this shaped the strategy that all nations relied on to control and to stop the spread of the disease. That was test, track, and treat became a universal mantra, essential for identifying cases, monitoring transmission, and guiding timely medical intervention across the world. RT-PCR testing, once a term known only to healthcare professionals like us, became a household word, at least in India, for the ordinary layman. RT-PCR kara lo bhi. This experience during the COVID pandemic understood that diagnostics are not just a foundational aspect of healthcare, but are indispensable in managing global health crisis. People got to know that you could not treat COVID without diagnosing it. Behind the scene, medical lab technologists are the ones responsible for carrying out these tests with precision, accuracy, and releasing the reports on time, making them the unsung heroes of evidence-based medicine. I often used to tell my own staff that you have to give the report on time. You see, we are the only ones who cannot dilly-dally. A clinician can say, ki aap kal aiyega, main test karaunga, kuch karunga. But you and I have to give the report in the time, and especially in private practice, he has given you the money in the morning, he has a receipt, so you have to give the report in the evening. He has already fixed up the appointment with the doctor. So if this is not done in a loose kind of a manner, either the disease will not be there or the patient will not be there. So you please remember that timing is very important of the report. Though these professions are rarely seen by patients, they play a pivotal role in the healthcare continuum. In fact, every diagnosis is a collaboration between the physician or the physician's knowledge and the lab technologist's skill. With the advancements in healthcare that leverage cutting-edge technologies to deliver accurate and personalized care, medical lab technologists will be at the forefront. Their role is expanding beyond traditional testing to encompass a blend of technological expertise, data interpretation, and collaborative clinical support. Lab medicine and diagnostics have always been at the forefront in adoption of technology. Who brought the analyzers or who brought computers into India first in healthcare? We did. Who automated the labs, auto-analyzers, etc.? We did. Therefore, it is imperative that today's laboratory scientists prepare for this evolving role and add skills to use the technologies for ensuring the highest quality of testing. Today, most analytical processes are automated with range of instruments from small automated analyzers to high throughput connected modular instruments, which are almost hands-free. But what still needs significant attention is the pre-analytical phase where 70% of lab errors occur. This is very important. This phase includes sample collection, labeling, transportation, and preparation. Addressing these errors requires not just technology, but a skilled human touch. Therefore, it is no surprise that Dr. Lal Path Labs, under its CSR flagship skill development program, through which over 7,500 lab phlebotomists have been created. We train
close to 3,000 phlebotomists every year, with the aim to create a cadre of highly skilled healthcare workers who can help reduce the burden of pre-analytical phase errors. And you understand that from a lab phlebotomist, he can go to the next step. He can become a junior lab technician or MLT, and then go on so forth. Once the samples are prepared, they enter the lab information management system, or what we call LIMS, which has become akin to the cardiovascular system of the lab. The LIMS connects all instruments, eliminating transcription errors, optimizing workflows, and maintaining strict quality metrics. Information technology, optic fiber-based Wi-Fi internet connectivity, and increased high-quality lab management system, or LIMS, will transform the role of a medical lab technologist, demanding not just clinical knowledge, but also a fluency in technology. You all will always be at the cutting edge of technology, I can assure you. The technologists have become as much data managers as they are scientists, ensuring seamless integration between machines and accurate diagnostic outcomes. But automation cannot entirely eliminate the need for specialized skills. Upskilling throughout an MLT's career is important, and honing specialized skills in areas that still need a lot of manual expertise should be paid attention to. Everything cannot be automated. Some of these fields include histopathology, special stains, molecular diagnostics, HPLC, electron microscopy, LCMS techniques, proteomics, etc. These are fields where the human touch, that is, in MLT's judgment, precision, and expertise is irreplaceable. Dr. Lal Path Labs, we run a program called Hunar for our internal lab scientists to provide specialized training and certifications on the job. I'm also happy to inform you that we are the biggest histopathology testing lab in the world by processing up to we process up to 1,400 biopsies in a day. As healthcare shifts towards personalized approaches, lab technologists play a crucial role in the performing genetic and molecular tests that drive individualized treatment plans. By analyzing genetic markers, cellular responses, and personalized health data, they help clinicians tailor therapies to each patient's unique profile, enhancing the effectiveness of treatments and thus providing an important facet of what we call personalized medicine. Diagnostics now involves managing and interpreting vast amounts of health data, requiring lab technologists to develop expertise in data analytics. So be careful. Now, this is what is going to come to you now. Working with big data will allow them to identify trends, provide insights for early diagnosis, and support predictive healthcare, helping to prevent illnesses before systems even arise. Another crucial focus area for technologists is quality. So remember, there are three things which ail Indian healthcare. One is accessibility, one is affordability, and the third one is quality. Don't want to go too much into it, but they are self-explanatory. The use of data and technology to continuously improve sample flow and quality of results is now an imperative. For example, implementing moving average for continuous quality measurement. This enables detection of systemic errors in instruments 24/7, and not just at the time of running quality controls. You all know that now. The modern medical lab technologist is no longer confined to just processing samples. They are now innovators, collaborators, and lifelong learners. They ensure that every diagnostic report is accurate, timely, and impactful for the patient's healthcare journey. Lab medicine today is far more than just mastering processing techniques. It is constantly pushing the envelope for learning skills that can ensure high-quality reports and value for each sample that is processed for the patients. In the future, I envision that lab technologists will need to collaborate even more closely with other professionals like clinicians, bioinformaticians, AI specialists, genetic counselors, etc., to interpret complex diagnostic data to provide holistic care. Their insights will be vital for guiding decisions, managing treatment courses, and facilitating communication within the patient care team. Medical lab technologists must take pride in knowing their work underpins evidence-based medicine, guiding clinical decisions and save lives. From addressing pre-analytical challenges, as we just discussed, to harnessing cutting-edge technologies. They are not just keeping pace with healthcare advancements. In fact, they are actively shaping the future. I would like to appeal to all of you to work towards attracting more candidates to pursue a career in medical lab sciences. Given the dynamic nature and the advancements in the field, it is becoming lucrative for the tech-savvy youth. We need more collaborative efforts between educational institutions, collaborative efforts between healthcare industry and the government to offer scholarships, internships, mentorship program that can further encourage young talent to choose MLT as a rewarding career path. I also firmly believe that medical lab technology can emerge as a large employer in the country. You know the problem in India. Mr. Modi has got lesser votes this time because of failure to create jobs. Please remember this. And this is where you come in. I also firmly believe that medical lab technology can emerge as a large employer in the country and contribute to the economic growth of numerous families and even the nation. This is a low-hanging fruit to provide employment to the youth of the country. India needs to create nearly 1 lakh jobs every month. That is more than 10 lakh jobs per year. And for that, you will not find many professions like medical lab technology, wherein within 2 years of passing class 12 exam, a person can become a respectable breadwinner for the family. With India's population reaching nearly 145 crores, and the increase in the burden of non-communicable diseases or NCDs like diabetes, hypertension, cardiac diseases, and strokes, liver, kidney, and lung diseases, etc., the role of lab medicine cannot be overemphasized. I said earlier that you will always be at the cutting edge, and you are at the cutting edge. Diagnosing these before the onset of a full-fledged disease would mean testing crores of people in their so-called good health, or what is known as preventive and wellness testing. By testing early at the primary health level, we can significantly lessen the burden during the advent of the full-blown disease, which then requires hospitalization in secondary and tertiary hospital like AIIMS. We can also increase the life of an individual by testing him in so-called wellness rather than in illness. This means that there will be literally, now this is the punchline, a 10-fold increase in the creation of phlebotomists and lab technologists in the changed scenario of healthcare in India. I envision that India sooner than later will adopt a policy wherein highly trained lab technologists will be running hundreds and thousands of clinical laboratories in India of the future, which are linked together with sophisticated digital networks ensuring high-quality diagnostics. According to an Indian Express report, there are 3 lakh laboratories in India, and from my calculation, it can grow by 10-fold. That is 30 lakh labs in India is what we require to handle a population like ours. But those labs have to be testing labs and not testing shops. You understand what I'm saying? Whether the healthcare administrators in India realize it or not, laboratory testing will be the #1 healthcare task to be fulfilled if India wants to control NCDs and prevent the 2% GDP loss caused by these NCDs. These NCDs bring down your financial ability of the country by 2% of the GDP. If we are to become the 3rd largest economy by 2027, lab medicine has to be given the #1 position in healthcare. As you all know, most of the NCDs can be reversed or arrested if detected in their initial stages. This means that lab medicine is going to see literally a volcanic explosion in the near future in the healthcare of the country. Thank you very much.
Thank you, sir. Thank you, Dr. Lal, for your enlightening lecture, defining the role and responsibilities of the laboratory medical professionals and as well as outlining a vision for the whole community in the near and even the distant future. So thank you, congratulate you again for this enlightening thing. Any questions, any thoughts? So if there are none, you have? Huh? Last bench, please come up. Please come ahead.
Good afternoon, sir. Sir, recently in our AIIMS,
Could you please introduce yourself also?
Sir, we recently set up a clinical toxicology lab in our department. So regarding this, I have a question that, is there any way that we can able to get a training in Dr. Lal for ICPMS and LCMS?
Yes, we do have internship programs, and you write to us, and I think we can accommodate you for some time for training purposes. It's not a problem.
So I think Dr. Lal has several training facilities and programs which helps in building up the the competence of the cadre, and I think those can be utilized very usefully. So if there are no more questions, I congratulate again Dr. Lal for his excellent speech, and thank you, sir. Thank you.
Thank you very much. Thank you.
Thank you so much, sir. We are proud to have you here. And your contribution to the field of laboratory professionals arena is indomitable, sir. Keep inspiring us, sir. Thank you. So the next talk is by Dr. Purva Mathur, and she's going to speak on the key performance indicators in clinical laboratory. She's a professor in Department of Laboratory Medicine, JPN ATC, AIIMS, New Delhi.
Our next speaker, Dr. Purva, she has been the torchbearer of hospital-acquired infections and has contributed significantly in this area. Moreover, recently the lab in trauma center has been accredited under her guidance, and also Dr. Arul Selvi. Both of them have made it possible that it has become the first lab in AIIMS which has got accreditation from NABL. Dr. Purva, please. Thank you. Have developed a latest integrated total end-to-end automation platform known as the Smart Lab, which you can take the opportunity to visit and make yourself aware of where what Dr. Lal was telling regarding automation, then the usage of AI technologies for auto validation, then QC monitoring, all those you can visualize in that lab. So it will be a good opportunity for all of you here to visit that lab and learn about the recent practices. Sir, Dr. Lal, sir, I'm also taking this time to make you aware that AIIMS has also taken this initiative to have NABL accreditation for all its major clinical diagnostic labs, and we are in that path. Our Department of Laboratory Medicine has already completed the audit and closed all the non-conformities raised, and we are in the process of getting accreditation for the whole department. So, and sometimes I would say that people, the lab staff, the technologists, the person working on the ground, they are apprehensive of a process called accreditation. Because you feel that somebody from outside is coming and looking into your processes to find out faults. I would like to assure you that it's not like that. It's a fact-finding process, and what happens is if we are looked at from outside, it always helps us to align our processes to the global requirements, to the standards prescribed. So always take these things in a very positive attitude. That would help us to move ahead, make our processes very well organized, well streamlined, so that it can ultimately give a better outcome for the patients with the available resources. Sir.
So I would like to take this platform to suggest to the organizers that next time when you have a conference like this, if you can all, come, give us time, and we can have, a phased amount of people. Our lab cannot, though it's a huge lab covering 1 acre of land in Rohini, but we can have small groups come at this time so that you can know that what I was trying to envision there, that you people are going to be making such labs in the future. So come and have a look, and we will work this thing out. And we do get people from the armed forces every year, but they are from the hospital administration department. But you people will benefit much more if you come and see that what we are up to. Thank you. By the way, we are the only lab in this part of the world which has 2 electron microscopes, when most of the labs don't even have 1. So that is a kind of, cutting edge technology we are talking about, and automation you come and see for yourself, and the high-ended tests and whatnot.
So has it been resolved? Okay. It will take 1 more minute.
I apologize for this delay and thank the co-chairs for giving me this opportunity, and I really congratulate this Indian Confederation of Medical Laboratory Technologies. As Dr. Lal mentioned very clearly that more than 70% of treatment is based on laboratory results, and that is how important the role of medical laboratory technologist is in today's era. And I often used to wonder, sir, that there are so many training programs for doctors and even nurses now, but medical laboratory technologist is one very, very important field and class of healthcare workers who are not given this opportunity of training. So it's a very welcome step, and we should have more of these training programs for medical laboratory technologists, because if a patient comes to a hospital, more often than not, some laboratory investigation will be ordered for that patient. And it's very important that we as laboratory people take utmost care in providing accurate results. And also we are in this era of accreditation of laboratories. All India Institute of Medical Sciences, under the leadership of Director of AIIMS, has taken this big step of accreditation of the entire laboratory ecosystem. So all the laboratory departments have been ordered to undergo NABL accreditation, and so that there is quality and there is trust that patients can have in the laboratory reports, and slowly all the laboratories are going into accreditation mode. So when you are going for any accreditation, or you are really concerned about the quality of laboratory reports that are generated, it's very important that you have something known as key performance indicators or quality indicators, which will guide you towards what are those indicators or what are those parameters that you really need to look into if you have to understand that whether your laboratory report is accurate, whether your performance is increasing over time, or it is static or reducing, or you need to do something about that. So we need to really understand what are these terms, key performance indicators, what are the ideal attributes of a key performance indicators, what are the factors that affect the laboratory performance, which have been amplified in the previous two speakers' speeches, that they are basically pre-analytical, analytical, and post-analyticals. Then just to touch upon a few KPIs which we use in the microbiology lab, and as Dr. Lal mentioned, there are few areas which are not totally automated, and sir mentioned about histopathology. microbiology is also one where there is automation, but a lot of hospitals, if we consider laboratory services given at district hospitals, many of these hospitals do not have any automation at all. And then how can these KPIs help in accuracy and efficiency of a healthcare facilities, laboratories? So what are these KPIs? These are evidence-based, data-driven measures that provide healthcare decision makers with ample tools to assess their data, highlight potential quality concerns, identify areas that need further study and investigation, and we can track changes over time. So these are very important when many of our laboratories here and all over India are going in for accreditation. So what are the attributes of an ideal KPI? So these quality indicators should be measurable and quantifiable. So it's not just out of the box that you just think that today I need to really include this as a quality indicator. That indicator must be measurable and quantifiable so that any person who is working in the lab can maintain a record of that. So it has to be very objective. It needs to be actionable so that if your KPI is off the chart, you have to take action. It should be easy to understand and can be taken from the existing data. So, it should be something which is very easy. It is done daily, monitored daily, and so that any person who is actually looking after the quality of a lab can use it. It should be priority driven because you have to, select the important areas which affect the quality of your lab. It should be comprehensive, so all areas, pre-analytical, analytical, and post-analytical must be covered whenever you decide on what KPIs you need to use, and there should not be overlap between different KPIs. So what are the factors that affect these three phases, the pre-analytical, analytical, and post-analytical phase? Most importantly, it's the pre-analytical phase that affects the quality of the results. It's like something like when we talk about computer science, the data entry part, it's like garbage in, garbage out. Whatever you are feeding into a system, the quality of the report will be dependent on what kind of samples you have collected, how you have transported to the laboratories, how you labeled your samples, whether there are any errors during labeling or taking the samples. So the test request, first of all, what kind of test is requisitioned by the physician, whether the resident has really understood what the consultant has ordered, preparation of the patient, how well have you instructed the patient? Of course, if there's a phlebotomist and it's a blood sample to be taken, the phlebotomist are trained, so you don't really need to prepare the patient. But if it's a sample in which the patient needs to be cooperated upon, if it's a sputum sample or a urine sample, you really have to instruct the patient on how to collect the sample, the collection technique, how you're really transporting the patient's sample, whether it needs cold storage. 2 days back, I attended a summit in ICMR in which they've developed a drone facility, when samples are transported from district hospitals to AIIMS Mangalgiri. So how the samples are transported, it's very important because sitting here at AIIMS, we don't realize that laboratory services are given even in areas which are very remote, We are under tuberculosis elimination program, so how the sputum samples have to be transported immediately to the laboratories. The accuracy of test order, patient identification, monitoring of specimen condition, how they are preserved, and the sample processing. So these are how the samples are received. So these are all the factors that affect the pre-analytical phase. Then factors that affect the analytical phase are the internal quality control, assay and instrument selection, because once a test request is there, a laboratory technician must know that what kind of samples to be put in which equipment and what are the quality controls that are needed. How do we centrifuge? The actual process of sample testing, which is the mainstay of any laboratory service. How often do you really retest? So if you have a very aware staff, you would know that, okay, there is an error in this report and I really need to retest that before that test is sent for verification, or inadvertently, if it is given to the patient, the technician who's sitting there must know whether actual retesting is required. reporting accuracy and interpretation. So this interpretation is very important in tests like histopathology, in microbiology, where a note is always added, So there is ambiguity sometimes in the sensitivity report. So interpretation of the laboratory results and also guidance to the doctor. So it's not just that you've just given the report and your job is done. Some kind of guidance on how do you interpret and what is the interpretation of that laboratory results. And then what are the factors that affect the post-analytical phase? It is the recording and releasing of the results, accuracy in transcription, report dispatch format, whether it is hard copy or LIS. So if it's a hard copy thing, one has to really ensure that the entry in the registers is accurate and the entry which is there in the actual report is very accurate, and the report which goes in the hands of the clinician of the patient is an accurate report. And then turnaround time. So if a report is delayed beyond a turnaround time which you have fixed for your own lab, it more often than not is not very useful for the patient treatment, So time is of essence. As Sir said, that a physician may defer a patient to the next OPD, but if the patient has given a sample to your lab or a clinician has requested a test result, turnaround time, the time that you take for the sample report to reach the clinicians or the patient is very important. Otherwise, all the exercise that you have done comes to a naught. So in the pre-analytical phase, it is important to remember that most of the laboratory errors occur during this phase. Therefore, your KPIs in this phase are necessary to keep these errors in check. So first KPI that you make is for the pre-analytical phase. Your laboratory must, study the pattern in the last 1 year, and you can make your own KPIs and understand that what are those parameters in the pre-analytical phase that you need to really include as a KPI. So it can be how many samples which were received in the wrong container, how many samples were leaking, or how many had improper form or not properly collected, not in a proper temperature. So you can make your own KPI. All the factors of the pre-analytical phase can be reasons for sample rejection. So you really cannot have 10 or 20 KPIs in the pre-analytical phase alone. Then you will be rejecting many, many more samples, and it will not be very good or positive for the patient outcome. So therefore, a sample rejection criteria with adequately documented and informed reasons will be very helpful. So you need to really assign KPIs, 2 or 3 most priority-driven important KPIs for the pre-analytical phase. If there are registration errors by the receptionist or staff, they are very important that you should document that. So whoever is sitting at the registration counter must be trained to understand that what are the KPIs they need to see as soon as the sample is received or comes to the lab. So to take action on these pre-analytical KPIs, it is important when you are informing the clinical areas, you have to really give guidance on how to improve the performance. You can't just say that, okay, we rejected this sample. You have to really give guidance to the clinicians on how, they can improve the sample collection techniques, how these KPIs affect the patient's report. If there's a leaky container and the sample has all leaked, you have to really inform the clinician that how this kind of sampling affects the patient reports, how it is ultimately risky for the patient. So if you see the NABL 2022 criteria, a lot of emphasis is put on risk. And this risk can be to the healthcare worker, it can be to the patient, it can be to those who are working in the laboratory. So giving a wrong report is the ultimate risk that you are giving to the patient. And risk mitigation is very important. So many of you are undergoing NABL, and I'm sure when the auditors come, they ask a lot of questions about risk mitigation. During analytical phase, it's our commitment to have good quality controls, how we manage equipment breakdowns and conduct the actual testing is very important. So these factors, there are many KPIs that you can include in the analytical phase, because this is one ecosystem which is entirely under your control. So you can record how many times your QC has failed, how many times you have to repeat, how many times your equipment broke down or your reagent failed. So you can have any of these KPIs. So some of the critical errors in chemistry and hematology have significant impact on patient outcomes and in the analytical role. In microbiology, for example, gram stain is taken as a critical report. You know, if there is a cerebrospinal fluid or a blood culture which is flagged positive, a report must be communicated to the clinicians immediately, and it's a critical alert. You know, if somebody does not report that, then it's an error on our part. So these are all the KPIs. How many critical errors were failed to be communicated? So it's a key KPI. So the lab is responsible for timely informing the critical error, and if it is not done, then you failed on a KPI and you have to take corrective action. And in the post-analytical phase, the correct entry and reporting of the result is essential, and transcriptional errors play an important role. So it is here that turnaround time is very important. So if you have a turnaround time of say 1 day or 24 hours, any result which is going beyond that, it's a key KPI that you have to really look into and take corrective action. So turnaround time is a critical KPI that needs to be included in your laboratory. So if there's any deviation in TAT, it's an area of improvement. Some high volume labs also use dashboards to check, you know, what is the TAT of their samples. And it is mandatory that all samples should have their TAT reported. It needs to be there in your SOPs, and it reflects the commitment that the laboratories have to deliver timely reports. So some of the KPIs that we use in our laboratory, and it's there in our manuals, these are the pre-analytical errors, the analytical errors, and the post-analytical errors. So this is how, you know, you have to make your own daily recording. You can enumerate your KPIs on the left, and on the right, these are the dates, and you can mention how many times your KPIs had failed. So in our microbiology laboratory trauma center, we have included rejection rate and registration error rate in the pre-analytical phase, blood culture contamination in the analytical indicator, and in the post-analytical, we have included transcriptional error, critical alert communication rate, and report error rate. So why is blood culture contamination taken as a KPI? It's very important because it is, first of all, as per the NHSN criteria and all the guidelines, like it's a guideline, and our own microbiology society take blood culture contamination as a KPI because it just tells us how well trained our healthcare workers are to take blood cultures for microbiology. So we have also included that in our SOP, that we have taken a threshold of 10% as the blood culture contamination rate. Now, how do we use these KPI to increase the efficiency of our lab? So all of them or a selected KPIs should be monitored monthly or as defined by the lab. This can be in the form of run charts, and a specific and designated threshold should be made for each KPI. So as I said, we have made a 10% blood culture contamination as a threshold to see whether we need to do something. So threshold definitions are very essential when you are establishing KPIs. And all laboratories can have your own, you can make your own threshold. It's not something which is written on the rocks that you have to have 3% or 10% or whatever error. You can make your own threshold, but be aware that if your threshold crosses that level, you have to take corrective actions. So this is the run chart in our own lab. We see that we have crossed these thresholds many times, and when this happens, we give trainings to the clinicians on how to collect the samples. So as we said that we have established our own threshold. So for rejection rate, we have established a rejection rate of 3%. If it exceeds 3%, then corrective measures have to be taken, like training of the staff, the phlebotomists, and those who are taking the samples to the lab. For blood culture contamination of 10%, there can be many reasons. There is turnaround of residents, and they have to be trained every time. So this is something which needs to be done on a monthly basis. So our residents are really actively involved in training the clinical residents on how to take culture samples. So, and another indicator which is very important is the EQUAS. You must have threshold established for EQUAS performance, because this is one very objective criteria when you are participating in an EQUAS. You must have threshold that any performance below that EQUAS threshold must be looked into. So we have established a threshold of 90% in our lab, And if it goes below 90%, that really calls for a meeting and understanding why the ECOWAS performance reduced. So how does KPI affect the diagnostic accuracy and efficiency? So if we improve all factors that affect the pre-analytical, analytical, and post-analytical phases, it helps in streamlining the process of test requisition forms, adequacy of sample, correct sample, internal quality control, external quality assurance, the upkeep of equipment, reagents, manpower training, and everything. So everything is in place if you have a good KPI data and you use it properly. So the end goal of KPI is to improve the system. It's a collective team effort of the laboratory. It may require extra effort, but knowing the area of improvement is a huge motivation and game changer. Bringing to a certain threshold may take some time and patience, so we all have taken time to reach to that level of accreditation. Without KPIs, we continue to work, but we will never know which area to improve. So it's a very good objective, method to improve performance of your lab, and you can choose your own threshold for KPIs. So thank you so much for your patient listening.
Thank you, Professor Purva, for your excellent, insightful talk, telling our laboratory professionals how to go about the KPIs, how to get them done, how to monitor them, how to use them. Any questions, any remarks from the audience? There's a question. Please, someone get the mic. Yes, sir.
Good afternoon, everybody. I'm Dr. Pankaj Kaul, Dean Allied Health Science, Riyadh Bhara University. Earlier, I was been working for 35 years in PGI. Sir, I have been seeing day in and day out, we are emphasizing more on this TAT. But accreditation, lab accreditation, and this NABL, it seems that it is taking more of our time and energy for doing all this paperwork and all that, and we are left with less time to do all this lab work, number one. And same thing is happening where the institution where I am serving, this NAAC, that is also creating a lot of data collection, and we are left with no time to reach to the student. So these two things are really pinching me, and my time is getting too much involved in these things. So is there any remedy? Should we promote this lab accreditations, or should we promote this NACs? Because we are not reaching to the patient, and in academic system, we are not reaching to the students, frankly speaking. Please emphasize on that. Thank you very much.
So, is this question directed to Dr. Purva?
No, I think you should answer that.
Okay, so I'll get Dr. Lal's perspective later, but to my mind, it's very important that sometimes we look back at ourselves. When we are doing work, we are trying to do quality work, and when we are trying to do quality work, sometimes it gets suppressed because of the workload that we have, especially in the government institutions, bigger institutions. You are from PGI here in AIIMS, and obviously some of the government institutions, we do not have probably the infrastructure to support these kind of activities. But when you are committing yourself to the quality, it's very important that at certain intervals we look back at ourselves that whether we are doing the things right or not. And sometimes it's better that somebody from outside, without the bias that we have inherently in our system, comes and looks at it, have a peek at it, and gives us some facts which are some scopes of improvements. So with that attitude, if we can make these activities part of our process, then over a period of time, maybe 2, 3, 5 years down the line, these things will become so much part of the process that we will not feel burdened that it's an overactivity. Maybe Dr. Lal can add to this. Sir.
See, the first thing which you have to do is to have the correct, full strength of your laboratory. If you are sanctioned, 25 people and you have only 18 of them, then what you are saying, makes a lot of sense. So if there's a shortage of pathologists, lab technicians, or whatever, so you have got to first make it up. Secondly, in this fast-moving world, which is very litigious world now, and you know what I mean, you will be rubbing your shoulders with some private lab who will say, no, my report is correct and your report is wrong. And the first thing the court will ask you, are you accredited? He says, yes, sir, I am accredited. And we faced a lot of such kind of things during the COVID, where all government labs said, हमें तो कोई check नहीं करना है, हमने करा है. I said, how? Because they used to say that, well, they found something positive or negative and we found just the opposite. So just because, you are a government lab doesn't mean that you're always right. So for your own safety, for the, the morale of your other people also, I think now accreditation is a must.
One more question, I think. We don't have much time. This will be the last question we'll take. Huh? Mike, please.
Good afternoon, everybody. I'm Dr. Monica Mahajan, Quality Manager from PJMEI, Chandigarh. I want to address Sir's question. Ours is an accredited lab, and we have 42 tests in the scope. And it was the first lab in PJ in a government setup. A whole department was accredited, which included many mycology diagnostic tests also. Sir is very right, but I just want to comment, we are facing this issue and we are accredited since 2014. And the thing is that once you start, you will find for first 2-3 years it is very, very difficult. But once the system, documentation, everything is in place, and you make it a point, like all the personnel concerned, whether a quality manager, deputy quality manager, technical managers, and all staff, that you devote 10 to 15 minutes daily, then the process become easy. And the patient work will also not suffer. So this is the point which all accredited labs should take into consideration.
Thank you, ma'am. Thank you for your inputs. And I remember at that time in 2014, I was in PGI Chandigarh, and this was mentioned especially in the director's speech on the Republic Day.
Yes, sir. That gives an honor every time.
It was an honor to have that lab accredited.
Yes. And that too with 42 tests in scope.
And whenever we do these kind of activities, the initial phase is always difficult. There are teething problems. However, if we make it a part of our practice, overall, over a period of time, it falls in place and probably it serves us better. So I will not take any more questions. Thank you, Dr. Purva, but before that, sir, some concluding remarks from you.
So, Dr. Purva, you have actually, touched the topic absolutely wholeheartedly in full detail. And my only earnest, desire is that all government labs also should be accredited. So the accreditation, of course, you have no time and we have no time, and everybody wants the report yesterday. The patients in our case are standing outside. So what you have to do is to hold your horses, as they say, and just keep going after quality, and the quality has to be there in each and every test, not just 42 tests or 50 tests. So this is another thing which I, am against, that a lab, all the tests which it carries out should be accredited by NABL, all, and not just part or, something like that. Thank you.
Just to mention here, Madam is the coordinator of NABL activities, and there is the chief coordinator, Dr. Bimal Das, but under Ma'am's guidance, all the labs at AIIMS are currently getting through the accreditation process. Thank you, ma'am. Thank you. Oh, one more, sir.
Madam, you must meet my better half. Her name is Dr. Vandana Lal. She's the chairman of the technical committee of NABL.
I know very well.
So you know her. So you should exchange notes with her.
I just want to add that we all have gone through, Dr. Sudeep will agree that when we started this process of NABL, we all felt overwhelmed. There is a lot of documentation, but that journey has been very beautiful. And to answer to your question that we are not reaching out to students, it's actually what we have experienced that the senior residents were very actively involved. So as a student, if they become aware of quality, it becomes a very beautiful process. And I must thank all the technicians of laboratory medicine at trauma center We've really become a team, and they talk of quality now. So it becomes a very integral part, and I think quality is important. If I go to a healthcare facility, I would really demand quality. So the government hospitals must come forth and show quality as the way.
Okay, thank you, ma'am. Big round of applause, please.
Thank you, ma'am. May I now request Padma Shri Dr. Arvind Lal sir to kindly present a memento to Purva Mathur ma'am.
As we start the second plenary session to talk about the recent regulatory and policy developments in MLS education and practices, I invite Dr. Pankaj Kaul, Dr. C.P. Pandey, and Mr. Sendil Kumar J. to chair the session. Dr. Pankaj Kaul, presently working as Dean in the University School of Allied Health Sciences, Raidbarai University, Mohali. He is a member expert in the Task Force Committee, Ministry of Health and Family Welfare, for revamping and recognizing medical laboratory sciences curriculum. He has more than 50 national and international conferences till date, and more than 11 national and international publications. Welcome, sir. Dr. C.P. Pandey is the Principal Technical Officer, CSIR, Lucknow, India. He's a manager of a science and technology facility with 35+ years of experience in a broad spectrum of research and development, namely holistic health systems, diagnostics, drug discovery, facility creation, and human resource development. Welcome, sir. Mr. J. Sendil Kumar, presently working as Technical Officer in Department of Biochemistry, JIPMA, has more than 26 years of experience. He persistently works towards the welfare of medical lab professionals, and associating himself with ICMLS, he has achieved many retrospective lab cadre restructure and MACP pursuance and implementation of revised curriculum for BMLS course. Welcome, sir. We happily invite Ms. Harvinder Kaur Lakhbir Singh to give us positive points on the strengthening medical laboratory sciences in Asia, overcoming challenges through Allied Health Act and mutual collaboration. We invite Dr. C.P. Pandey to introduce our speaker.
Well, we welcome out here Ms. Harvinder Kaur Lakhbir Singh from Singapore. She is an Executive Council member, Malaysian Institute of Medical Laboratory Sciences, that is MIMLS. She is knowledgeable in OHSAS 18001 and MS 1722, management systems, and standards including laboratory structure, planning activities, and resources for developing and maintaining the organization's OH&S policy, extensive knowledge of product testing, microbiology methods, comprehensive knowledge of MSQH and ISO 15189, requirements for laboratory accreditation, well informed with the Biosafety Act 2007, Act 678, and the Pathology Act 2007 on the working committee for the AHP Act 774. She has managed and completed laboratory incidents investigations. Welcome, Ms. Harvinder Kaur. Over to you now.
Thank you. Namaskar, Sat Sri Akal, and Assalamu Alaikum. आप सबको इस अवसर पर अच्छा, हम सब जानते हैं कि ज्ञान एक ऐसी शक्ति है जो हम बांटने से बढ़ती है. And ladies and gentlemen, with that, I would like to take a moment to continue my speech in English. Thank you very much. Okay, based on what we have learned and noted just now, we all know that strengthening of medical laboratory sciences, we have to overcome some certain challenges that we have faced in terms of the Act as well as regulation in different countries. My talk today will talk about how we can overcome this via mutual collaboration across Asia. Now, as we all know, not only in India, but across Asia, our role as a medical lab scientist, medical lab technologies, is in disease monitoring and public health surveillance. We support accurate diagnosis for a patient. We also support disease prevention and we enable effective treatment. But there is a lot of fragmentation as well as lack of regulation in many countries. And as we all know, it was stated earlier on, 70% of our medical decisions rely on our accurate lab results because we are an indispensable part of the whole healthcare system. Now, how do we elevate the recognition and status of the allied health without an Allied Health Act? How is it professional associations, just like ICMLS, can establish the strengthening of the professional association? How is it different national associations will be able to support career developments for the medical lab scientists? How do we continue education? And how do we advocate for better working conditions? Across Asia, this is one of the bane of this occupation. Now, Dr. Lal just now spoke about increased workforce capacity. As the demand for laboratory services increases across Asia, due to population growth, due to aging healthcare, there is an increased burden for regulatory acts to enhance our professional recognition, as well as to encourage more individuals to enter the profession. We all have talked about the code of ethics. We have all talked about disciplinary mechanisms. But how is it via strengthening of mutual collaboration, this code of ethics and this disciplinary mechanism will be able to help Asian countries? Now, my take on this is very simple. When you have a code of ethics, it guides your work day to day. This code of ethics will give you integrity in terms of performing your job, right? This includes, we talked about patient safety, professional behavior, appropriate use of laboratory technology, and patient confidentiality. Disciplinary mechanism. Now, typically what we want an act to do is, we want it to be able to help us to perform any investigation on misconduct. We want it to be able to get a career pathway so that the medical lab fraternity is held accountable for the job that we do. The moment we take accountability for our job is the moment the profession gets recognition across the world. So that is why having an act, having a way, a so-called disciplinary mechanism will help to further enhance this act. Okay? We also know that we need to protect the integrity of our profession and ensure quality delivery. Just now, Dr. Kalra, the first plenary, spoke about admitting our mistakes. Yes, we can admit our mistakes, but what then? What sort of disciplinary mechanism do we have? How does it protect the person who made the mistake? If or when the person says, yes, I did a mistake, this is the mistake that I did, as Dr. Kalra said, it should be non-punitive. We don't want to punish anybody. the fact that we have ISO 15189 in order to know what sort of problems that we occurred in order to be better is a sort of disciplinary mechanism that we can actually employ across Asia, because ISO 15189, the current one talks a lot about risk management. So my take on this is, the moment we want to do a disciplinary mechanism, start thinking about what if? What if the test that I did didn't give me an appropriate result? What if the technology that I am using is not appropriate for the test that is ordered? And in this way, the disciplinary mechanism will be able to enhance not only the profession, but also the reporting of any problems as well as errors. Now, we talk about educational institutions. We have a lot of educational institutions here in India, AIIMS, PIG, right? All these institutions offer a lot of MLS programs, but the accreditation of these schools to maintain national and international standards should also come hand in hand, besides only accrediting the profession as a whole. So if the institution is accredited, it will be able to give quality programs to equip the students to meet the demands of the modern laboratory practices. Curriculum development. I was told that there is a lot of work being done in terms of curriculum development in India, right? Just like Malaysia, India, Thailand, we have developed specialized programs for medical laboratory sciences that covers most of the molecular diagnostics, bioinformatics, and quality management. I'll give you a small example. In Thailand, for their radiographers until today, there is part of their curriculum that teaches them how to develop negative films, which is not viable anymore in this modern era. But because there is an act in Thailand, then the curriculum development came hand in hand. Okay, I'll just give you a little bit of history. This was the first act that was done in 1958. Okay, this was done by the Korean ministry at that time. At that time, there was no laboratory scientist. The term that they used was clinical laboratory technician. And this was somebody who was under the Minister of Health, Labor and Welfare, who was conducting microbiological examinations, serological examinations. Okay, so they specified who are the people that come under this act. And since then, since 1958, this act has been revised 10 times in order to keep up with the latest development as well as to keep up with global technology. Now, the next act that came into play was the Japan Medical Technologies Act. This was revised in 2014. Okay. Under these key provisions that they had was, the medical lab technologies must complete recognized education program and have a national examination to practice. The Japan Medical Act also mandates that ongoing professional development and clinical guidelines to maintain a high standard of services. In Japan, the medical technologies also have specific roles in quality assurance and operation of diagnostic technologies. Now, this didn't happen in a blink of an eye. 1958 to 2026, it has been 60 years that these people have been fighting for their right and regulating their profession. Okay? Then we have the other acts that we have, South Korea Act 1962, and then we also have the Philippines Medical Technology Act. What I would like to show here is the fact that all of these acts, they have a licensing and regulatory body, and their main scope of practice outlines the roles and the responsibilities of the MLT when they are performing laboratory tests. Over these two, as you can see, they have a professional regulation committee or commissions that has people from their profession regulating their work. These are some of the newer acts that came into play, as you can see here. This is the Thailand Medical Profession Act. It was in 2001. So if you can see, from Taiwan, Korea, Japan, then it went down to Thailand. There was a very big gap in terms of regulating across Asia. Why? Because at that time, there was no mutual collaboration. So now once that Thailand came into the Asian Association of Medical Lab Sciences, which is an organization that I chair, we decided to share with everybody what is happening in terms Korea, Japan, as well as Taiwan. So same here also, the scope, the purpose of each act was harmonized. Okay. Then we have Malaysia. We started in 2016. So this act came after Indonesia. Indonesia started in 2014. And now, as you all know, India has its own act, which is still under preview, that you all did in 2021, but has yet to establish a working committee. I was informed that ICMLS as well as another group of technicians have recently taken the government to the Supreme Court in order to establish this committee. The fact that you are fighting for your profession to be regulated, kudos to all of y'all, but a note of precaution. It is not going to be easy, it is not going to be fast, neither is it going to be simple. Okay, so joining an association like ICMLS and making ICMLS strong in terms of members will help the profession to become better. So ICMLS, as I know, they are working with the National Regulatory Framework. They are talking about patient safety as well as MLS education. These are core across Asian, any associations that we have. These three things are core components of our associations. Now, what are the challenges that we face in Asia? All of our regulatory frameworks are fragmented, okay? And this actually affects quality control and patient safety. Across Asia, we have a lot of educational and training gaps. For example, India, Malaysia, we still have the diploma in medical laboratory technology. Whereas other countries across Asia, they have already done it as a bachelor's program, 4 years. Okay, so that is one thing that we should think about in terms of training gaps. In Malaysia, we have given a time frame. By 2030, we shall abolish our diploma programs in order for us to all be under one name, which is the Medical Lab Sciences. So the diploma program will be abolished in 2030 in order for us to be on par, as well as to be consistent in our curriculum, our certification across Asia, and our professional development opportunities. Now, if everybody were to have one regulated examination across Asia, then career opportunities will also be easy. For example, Korea, Taiwan, and Japan, they have one exam that they sit for, and if you pass this exam, you can work in either one of these countries. Okay? Resource limitation and access. Most countries in Asia, as we know, we have limited funding. When we want to go for conferences, when we want to, publish our scientific papers, the amount that is needed to publish in a Tier 1 publication, an ISI index publication, takes a lot of money. And this is something that we should overcome by having mutual collaboration. Okay? Insufficient infrastructure and access, even in Malaysia, in East Malaysia, Sabah, Sarawak, our laboratory infrastructure is so bad that most of the time we do point of care testing for them. Okay? Access to essential diagnostic tools and reagents in lower resource setting. Now, for me, I feel that as medical lab technologists, there are many ways that we can overcome these problems. Instead of buying reagents, we can follow Korea and Taiwan and make our own reagents and get it certified by the national accredited body. As long as you do a cross-match benching, we should be able to have our own reagents and not depend on the whole country. I'll give you an example. During COVID, my lab was able to produce vials of the media, our virus media, in order to do the culturing as well as PCR, right? So we had the resources to produce our own, and we didn't have to rely on any other countries to give us that media in order to be able to replicate the COVID virus before we did our PCR. This is something that I think is a very good take-home message across Asia. As long as your country has the brain, as long as your country is able to give you some sort of resource to do your own reagents and media, that country will flourish. Okay? Now, these are some of my suggestions for further collaboration and regulatory improvements. Unified curriculum standards across Asia. This is very important. Data and research sharing consortium. Again, if this can happen, it will be marvelous for the scientists across Asia. We also have something that I have been proposing for quite some time now, known as the Asian Mutual Recognition Arrangements, MRA, for the allied health. A little bit about the Asian Association's laboratory sciences role as a catalyst. So I'm sure ICMLS, a few of the board members have been to a few of the AIIMS Congress across Asia. So besides having the Congress, we also try to strive, just like today, there were a lot of them who received lifetime achievements. We also try to do the same, and we open this up to all national bodies who are our members to promote your scientists. For example, our AIIMLS honors, we had Dr. Kaptan Singh Ji for the AIIMLS Professional Awards that was given to him in Kuala Lumpur, in Korea. Okay, then we also had something known as My Hero. During My Hero, Dr. Malkit Singh from Chandigarh was given a stage to speak upon, to talk about how is it that he developed his data on ethics. Okay, so I feel that being part of a bigger association across Asia will actually help us know what other countries are doing. How is it that they are progressing in terms of the allied health? How do we help each other in terms of the allied health? How do we make the profession move forward in such that all of us will be globally recognized no matter where we go? Okay? And before I end my talk for today, I would like to say that sharing of knowledge, okay, will only help us gain better knowledge. So with that, I thank all of you. Thank you. Questions? Any questions?
Any questions? Please.
Thank you, ma'am. Thank you for joining ICMLS, and it's been a privilege to meet you again after Korea here. Ma'am, this question is on behalf of all the students and upcoming medical scientists sitting here. Like those who are studying in India, if they would like to work in Malaysia or any of other Asian countries, does they need to appear for some examinations? Or, and another question is, does these other Asian accrediting bodies recognize our Indian curriculum, which is a national curriculum now? So these are the two questions from my side.
Okay, so under our Act 774, we actually have a role for those who come from different countries. The only criteria is whichever institution that you come from, your curriculum must be aligned to the Malaysian MQA, Malaysian Qualifying Agency curriculum. So as long as these two curriculums are aligned, we have given a provision for those from foreign countries to come and work with an allied health license, as we call it, for 1 year. So in that term, we have given it, but you must also understand for other Asian countries, for example, Singapore. Singapore doesn't have the MLS, the Medical Lab Scientist profession, is not part of the Allied Health Act. So they are not regulated. Where else, Taiwan, Korea, and Japan, it is a necessity to speak their language because the examination is conducted in their language. So that further makes the pool smaller. So we are left with Malaysia, Thailand, Brunei, Indonesia, And hopefully, as we move bigger, I hope to include Australia and New Zealand as well as part of this Asian collaboration.
Anyone else? Thanks, Madam Harvinder Kaur. You have got a very big name, Miss Harvinder Kaur Lakbir Singh. So it was a wonderful talk you have given. And as far as you were talking about ethics, I think there are four pillars of this ethics. First of all is we have to educate our people. Education is a must. Until and unless we have education, we cannot reach to any place. Then comes professionalism. But once you are a professional, you will respect your own job where you are working. And our job is not a job, it is a profession. Once you are in profession, then time clock goes away. You have to give full satisfactory results to the patient. That is very important. And for that, you must have an attitude, positive attitude you have to be there. And once you have got that, and after that, sharing of knowledge is a must. This is a platform for which we have made this conference, that there is a knowledge sharing should be there. So these are the four pillars, I think, on which our ethics can work. And moreover, ma'am, you had some apprehension about diploma and all that. In our model curriculum also in 2016, it has been mentioned specifically that diploma will be removed should be removed in phased manner. So much of industry is working on diploma. Even I was also forced to continue diploma. So many people, they are art students, they are getting diploma of MLS because they are not getting job in arts. So they are coming towards our side in medical science. So this diploma should be removed, and this is very nice that now we have got graduation. In your institution also, probably in your country also, there must be a graduation. And PGI Chandigarh was the first institute to have entry qualification as BSc Medical Technology. Even in AIIMS still their entry qualification is diploma, but they are preferring graduates. But there has to be a uniform pattern throughout India. And the amount of work, ma'am, you have done in Malaysia, I wish you could have done in India also, so that Kaptanji gets some better support, because we are useless for him now because we are busy in our own course, but Kaptanji needs a lot of this support. And he had been doing a yeoman's job in joining professionals in India as well as at international level. And madam, with this, I thank you very much for your nice and beautiful talk. Thank you.
Thank you so much. Before I leave, Karam Karte Chalo, science is the lamp that illuminates everything on earth. Thank you.
Thank you, ma'am, for that motivating talk. I request our ICMLS President, Dr. Kaptan Singh Sehrawat, to kindly present a memento to our speaker. Thank you, ma'am. The next talk is on NCAHP Act 2021, current implementation status, future possibilities, and challenges for Indian medical laboratory professionals by Dr. Kaptan Singh Sehrawat. So this will be the last talk for the forenoon session before we break for the lunch. I now request Dr. C.P. Pandey to introduce Dr. Kaptan Singh Sehrawat.
Well, big round of applause for the real leader, Dr. Kaptan Singh Sehrawat. I don't think he requires any introduction as such. He has been the founder of ICMLS, and lot many things are being displayed over here. If I start narrating all those, it'll take at least like 10 minutes to go through them. So we are short of time, and especially for the students, He is an inspiration for all of us who are here. We are here because of his leadership quality, and luckily, by chance or coincidence, he has got a name which itself means leader, Kaptan, the real captain. He was a chief delegate of ICMLS in International Federation of Biomedical Sciences. He is general secretary of JFMTI. I mean, two great organizations. At one place, he is general secretary. At ICMLS, he is the president and chairman of International Committee on Standardization and Augmentation of Clinical Lab Program Profession, general secretary of LHMC and Associated Hospitals, Medical Laboratory Technologists Association. He is founder of National Medical Laboratory Professional Week, NMLPW India. So now I hand over the mic to Dr. Kaptan Singh Sehrawat, please.
Okay. Yeah, I'll not take much time before this lunch, so just within 10 minutes, because we have a panel discussion on this topic. Thank you, sir, for the introduction. This is basically just an overview of the basically current updates with reference to the NCHP Act. So in terms of lab, if we look back in the history of lab sciences, particularly in the context of India or global level also. So after the World War I, the first time it was realized globally that there should be a other workforce in healthcare after doctor and nurses. So earlier, you know, only medical facilities were managed by the doctors and nursing personnel. Demand of medical lab professionals was realized after First World War and subsequently after Second World War also. So if we'll look back in the history of 100 years, then second time after 100 years almost, in 2019 during the COVID pandemic, it was realized again by the world that yes, there is a need of trained, qualified medical lab professional everywhere. So this is basically just to say that 100 years have transformed the entire this profession. That time just medical assistants were there. Now we have a pool of very qualified, trained technocrats, and even having the doctorate in medical laboratory sciences. We have very sophisticated technology worldwide. So historically, yes, number of tests were less. Now number of tests are increasing. Very few limited tools and techniques were there. Now we have technological advancements are there. No formal trainings were there. Now we have formal training programs globally. So if in context of globally, if we'll see that in 1922, if I'm not wrong, the University of Minnesota was the first to start this program for the laboratory technicians. And when I was searching for that Indian literature, it was found that CMC Vellore was the first institute which started because that time British era was there in India, and it was started in 1927 in CMC Vellore. So as far as the degree program is concerned, PGI Chandigarh and JIPMER Puducherry was the first institute to start this formal programs, degree programs, almost 60 years back in 1967 or 65. So this is a journey basically of the medical lab profession worldwide. Now we have sophisticated technology. But today our purpose is not to talk about the history or this process. Again, since the complexities are also increasing, challenges are also there. When we are growing, we have a lot of challenges also of the quality, patient safety, regulation, standardization of education globally, as already discussed by Madam Harvinder. So we are dealing with very global issues at global level also. So as far as India is concerned, we have approximate 5 to 6 lakh workforce posted in state government, central hospital institutions, private healthcare establishment, more than 50 different small and big associations. India is a big country, even state level, institutional level associations are in existence. ICMLS, MLTA are two big bodies, professional bodies. And now we have a regulatory framework also under NCHP Act, which is in process of implementation. More than 500 medical laboratory colleges are running the programs right now. We have very diverse work environment in state, central, and this local bodies. So when we talk about the quest for regulatory body in India, this was a major issue for, we were demanding for this regulator. So luckily after in 2020 to 19 and after 19 to in 2021, when first time after 100 years it was again realized by the world that yes, laboratories are in the center of healthcare. So our government has also speed up the process, and this bill was passed. You can see the journey of this legislative process. It was actively started in 1995 in the parliamentary process, and I'll not discuss much about this process. So finally in 2021, on 24th March 2021, a bill was passed and notified just after a few days in 28th March in Parliament. So what is basically NCHP Act? NCHP Act is now a common act in line with the Malaysia and other countries. We have also a common regulator for the 56 categories of health sciences. Medical Lab and Life Sciences Professional Council is the #1 council, which is going to be a big council under this act. So again, the purpose is very similar to in line with the other global bodies regulators. It has a long legislative history, and these are the 56 categories of allied health and healthcare workforce which are part of this act. So you can see the list is very big. So challenges are also very comparatively very high if we'll compare with the other countries, because it's a big act. As per my knowledge and understanding, this is one of the big legislation where more than 56 categories are to be regulated in a single act. So this is one of the document which was referred during the classification of the allied health workforce in two different domains. One is allied health professional, second was healthcare professional. Although there are few disagreement with reference to this this document, ISCO 08, but still, since it's a beginning, we cannot raise multiple issues. We are in a process, transition time, and in the process of implementation. So after some time, when the regulator will be fully functional, we can raise these issues to amend the schedules also. So these are the definitions. Less than 2 years of program will not be under this purview of the NCHP Act. If you are seeking a recognized diploma program, that means minimum 2 years of durations, and there is a clear definition of hours also, educational hours. And when we talk about the degree also, degree has minimum number of hours is required for that. So these are the 10 major councils which are to be established, and 10 councils means 56 categories of allied and healthcare shall be divided into these 10 councils classified. So this is a framework I will discuss in the next upcoming session also. This is a big umbrella level framework, national level framework. Central government have very monitoring role right now and in commission. So there will be no such type of election which were occurred in the earlier regulatory frameworks. So the nominations will be there from the government in different bodies at state level or central level. So this is a framework. These are the important sections. So our audience and leadership will be more interested in what is happening now. What is the current status of this act now? This is the almost last slide. So just. ये PDF है just a minute. No, or otherwise from outside we can just back side. Yes, just a minute. Okay, this is the last slide. Basically, this is a very latest documents which has been filed by the government of India on behalf of the NCHP Act just on this 12th November in Supreme Court. Since we are a party, we are a petitioner organization there in Supreme Court. So this is the largest issue of allied health workforce. So they have, as per the direction of the Honorable Supreme Court, they have organized multiple meetings. The Ministry of Health was directed to hold the meeting with all state and UTs, 42 states and UTs, and to to file a compliance affidavit before the Supreme Court. So they have already organized various meetings. So now the current status is just state-wise we have a, just a minute, status report. This is a big document showing that Government of India is saying that we are doing lot of efforts with the states, and this is the current affidavit, current status, and on observation of the NCHP Act state-wise. Just last slides. Andhra Pradesh government, state government is saying that this is the observation from the, when the central government has filed the affidavit. Again, the observations were submitted by the NCHP, National Commission, which is now in position. So what the commission is saying, because just 4 days back they have filed this affidavit, this is the most latest information now. So government of Andhra Pradesh had initially constituted Andhra Pradesh State Allied and Healthcare Council with 4 members on 17/3/2022. Further 8 members have been appointed on 27/4/2023. This is the update from the Andhra Pradesh. For Arunachal Pradesh, the Allied Health Council and 2 autonomous board were constituted by the government of Arunachal Pradesh, wide notification so and so. Government of Arunachal Pradesh has framed the draft rules, and the same is to be placed before this state cabinet for the approval and notifications. A medical laboratory technologist has been nominated as part-time member from the state council as per the provision of this and this. Initially an interim chairperson was appointed for the state council. The process for appointment of regular chairperson has been initiated, and required financial budget for the same has been prepared. This has been submitted to the Department for Finance, Government of Arunachal. Every state is like a country. So every state has their own administrative mechanism to approve, to take the approval and to establish all these things. So then I feel this is a big summary of all states. We will discuss in upcoming our session. So state-wise they have filed the affidavit. It is better to discuss state-wise with the participants what is happening in their respective state. We'll take the questions from. So this is entire India is now compelled to file the status report, and they have filed it, and we are waiting for the next direction from the Honorable Supreme Court. So even Government of Delhi, which was silent earlier, now they are saying that draft rules have been prepared and has been forwarded to the Lord for waiting. The process for selection of the member as per the section NCHP Act is underway. Recommendations have been received for these members. So a lot of things, even Chandigarh, everywhere. This is a complete documents. So this was just to share, and we'll, regarding the future insight of the profession, how we'll move for the future. We have lot of challenges as well, lot of opportunities as well. So what is our leadership perspective? What is the ICMLS vision, mission for this thing? We'll share in the upcoming panel discussion. Thank you very much. Thank you.
Well, it's a very huge topic basically, and that's why we have put up a panel discussion in the post-lunch session. Thank you, Dr. Kaptan Singh, for giving an elaborate overview on this. Probably we can ask questions in the later session. Since we are already we have behind time, we have crossed almost half an hour for lunch, so we'll disperse for lunch. Thank you once again, Dr. Kaptan Singh Sehrawat, for such a wonderful presentation. Thank you. We'll get together again at 2:30. Please try to be here at 2:30.
Thank you, sir.